identified in our curriculum that we don't talk a lot about here at Bellarmine is sex, which is really interesting. We don't talk about sexuality very much in our curriculum. So you would think in the OB class that, well, we should really talk about sex. So, everybody has sex. Some are intimate in other ways, and so we would want to address that with our patients in pregnancy. So just because you're pregnant doesn't mean you can't be intimate with your partner. So for most patients, the vast majority of patients, you can have sexual activity the entire pregnancy, okay? But there is some modifications you may need to make because of the discomforts of pregnancy. So for example, at the beginning of pregnancy, there's breast tenderness, there's nausea and vomiting. A lot of women have a decreased libido, which is a desire to be intimate with their partner, and sometimes again that's due to the hormone fluctuations that occur in first trimester. In third trimester, because of the enlarging uterus, it's again more challenging. You have more pelvic pressure. When you talk with a lot of women, because of the way the pelvic floor is, the baby literally feels like the baby's moving like between her legs. So we're going to talk about one of the myths about having sex when you're pregnant, okay? Will his penis touch the baby, right? That is a very common question women have. The answer is no, okay? Now, when you're being intimate, might the baby move during sex? Yes, okay? And some people get that circumvents their mood a lot, okay? The other thing to be mindful of is, while for some women it's great because you're not worried about getting pregnant because you are pregnant, so contraception, you might have to not worry about contraception. We do still have to worry about sexually transmitted infections. So again, if you're having sex with someone and there's the risk of syphilis, gonorrhea, chlamydia, herpes, HIV, things like that, we would need to screen our patient for that, so we want to ask about that. The other thing is alternatives to intercourse, so being intimate with your partner. We do tend to recommend to pregnant women to avoid anal sex. And the reason why is, again, it just introduces pathogens. You can often tear the rectum. It's very vascular. So we would discourage women from having anal sex. But one of the big things that is successful for women is changing positions. So sometimes if a woman's on top instead of on the bottom, and then we don't want her flat on her back because of being a cava syndrome. And then it's important to educate women that sometimes when you have an orgasm, because of the hormones that are released, you might have contractions following having an orgasm. That's a very normal phenomenon. There are some women who are advised not to have sex. So they are on pelvic rest. And what that means is no stimulation, no sexual intercourse, intimacy, or anything like that. And those are women who are at risk of premature contractions, premature labor, premature delivery. And they often will say nothing in the vagina at all. And again, no manual stimulation or anything like that at all. So only if you're on pelvic rest, and again, it's very few patients that are advised to avoid that. With breast stimulation, causes the release not only of prolactin but oxytocin, which can also cause contractions. So it's not even just intercourse that can cause contractions. In terms of taking care of your teeth, you want to make sure that you have really extensive dental work done, hopefully prior to pregnancy. Smokers have really bad oral hygiene, so that's a cue in if you see someone with really bad oral hygiene that they may be a smoker. Sometimes they're losing teeth, have rotting teeth. Patients who don't have good teeth can't eat good, nutritious foods. Ideally, people should be brushing their teeth and flossing. Vitamins should help. Remember, it's common to have swollen, kind of bleeding gums. So when patients brush their teeth and floss, they might have a little bit of bleeding gums with that. So again, using some type of oral rinse will help prevent gingivitis and gum disease. And ideally, you're supposed to have your teeth cleaned every 6 months. So some point during pregnancy, you would have your teeth cleaned. All right, so immunizations. This is one of McNeely's pet peeves. So I would make sure that you make note of this. This is a lot of information, but I just want to simplify it for you so it makes it super easy to remember. There are only 2 no's that you need to worry about, MMR and varicella. Pretty much anything else about when we talk about vaccinations that we commonly give to people, we're talking about common vaccinations. They're okay to give in pregnancy. so what does that mean for us? For us, it means things like the flu vaccine, DTaP. We could give pneumococcal vaccine, but we don't generally give that to, it's usually, that's reserved for people who have some type of chronic health condition or over the age of 65. But the big players for us tend to be flu, DTaP. So let's talk about a couple of little odd things. PPD is not a vaccination. Could I give a PPD to a pregnant woman? I can, but again, you guys know PPDs are not the best thing in the world. There's a lot of false positives and false negatives. So if I have a woman who's at concern for exposure to TB in pregnancy, they probably would do a blood test rather than a PPD because the blood test is better, more precision. TB in pregnancy is difficult because again, the meds that we use for TB are not tolerated well in pregnancy. They impact the liver, so it causes just a whole cascade of problems. And again, we don't see a whole lot of that here in our community, but in other parts of the world, you would see that. So again, the big common vaccinations, the two we would avoid in pregnancy, varicella, which is chickenpox, and MMR, measles, mumps, rubella. Even if she's rubella non-immune, even if she's rubella non-immune. And then we can vaccinate for both of those during the postpartum period. In pharmacology, I don't know if you guys talked about this, and I can't remember if this was on your drug cards or not. It's old, like this lettering system, but a lot of people still refer to that. So this A, B, C, D, and X, they got rid of it because people got confused by it. In 2014, there was a new rule with medications, and one of the big things is with some of our medications, we don't have a lot of information about how safe it is in pregnancy or lactation. Some meds we will give to pregnant women, so like Pitocin is actually a category X drug, but we give it to pregnant women to help them have a baby. So that's, I think, some of the confusion there. So where do you go in doubt about whether or not a patient can take a particular medication that they're using for blood pressure? Maybe they're hypertensive, or they have asthma, or they have some type of chronic health condition, irritable bowel syndrome. Usually where we start with is looking at the drug reference guide. We can, again, talk to both the specialists on both ends, so you might talk to the OB, but then also talk to the pulmonologist or the endocrinologist or whatever. We try to, a lot of times the older the drug is, the safer it is, and the more simple the drug is. So rather than, again, a newer drug, one that is a combination drug, we actually will put patients on older, safer medications. The other thing is there are some drugs that we will not give during pregnancy. And so it's really important that you do medication reconciliation with your patients to make sure they're not taking any of those leftover meds. We talk about clearing out your cabinets of old drugs, and some people are like, oh, it feels like I've got that infection again. I've got some antibiotics left over from 6 months ago. You do not want patients doing that. They should not be kind of self-diagnosing and taking medications on their own during pregnancy. Smoking in pregnancy is bad. We have a lot of pregnant smokers here in Kentucky. And so one of the things about pregnancy and smoking, a lot of women decrease the amount that they're smoking in pregnancy, which is good. Smoking is an opportune time, but remember, the riskiest time is right at the beginning. And so what happens if you smoke a lot? You can have miscarriage, so you can lose the baby. The baby can be very small. It usually has to do something with perfusion. So the baby is very small. It could have long-term consequences in terms of growth. Those babies often are at risk of SIDS, asthma, cognitive decline. They may have learning difficulties, developmental delays. So again, a lot of risks related to smoking. So any decrease is good. And again, the best predictor of being successful with stopping smoking is if you can get other people in the household to stop smoking as well. For some women, what happens is they switch to vaping, so they think they're healthier because they've switched to e-cigarettes or vaping or whatever. And again, we would discourage the use of that. So what about nicotine replacement therapy? Nicotine replacement therapy has really mixed data in terms of whether or not it is successful. And the other concern about nicotine replacement therapy, nicotine is a vasoconstrictor. And that's one of our big concerns with smoking, is that we're restricting perfusion to the baby. So is nicotine replacement therapy more harmful, less harmful than smoking? Again, you see some different things on that, and I've seen different providers talk about this. We've kind of had a pendulum where we had people on NRT, and then we took them and said, no, let's not use NRT at all. Because the other thing they found is that patients who were using a nicotine replacement therapy were still continuing to smoke, which just made the vasoconstriction that much worse. So these are the steps, and talking about asking someone and arranging smoking cessation problems. So always ask about tobacco use. And maybe the patient just found out she was pregnant and just quit smoking 2 weeks ago. So the advice you give that patient may be different than someone who's never smoked. The other thing is you also want to know about secondhand smoke, because we want to minimize mom's exposure to secondhand smoke as well. Always be direct and advise the patient to quit smoking. This is a key one, assess the willingness to quit. For a lot of women, the motivation is, now that I have another person to take care of, I want to be there to see my baby grow up. This is the time that I can quit smoking. Now, what happens in real life is some women quit smoking during pregnancy, which is great. But as soon as they deliver the baby, they go right outside the hospital and puff up as quick as they can. And we really want to try and keep them smoke-free after they have the baby. So that, again, we want to give them connections with how they can quit, but this follow-up care is really important. So someone who says they've stopped smoking during pregnancy, we want to make sure, because relapse is very common, and help them stay smoke-free after delivery. So there's some PO medications that are used to help with people in smoking cessation. A lot of these are antidepressants. So you'll talk a little bit about these in psych. You may have talked about them a little bit in pharm. And again, we don't have a lot of evidence there about using that successfully in pregnancy. Alcohol. Alcohol in pregnancy, the recommendation is no alcohol whatsoever in pregnancy. And really it's recommended, if you're thinking about having a baby, to abstain from alcohol. When we look at babies born with fetal alcohol syndrome, it's along a spectrum. So it can, again, be any kind of, at what point did the exposure occur? How much alcohol did the patient have? So this is what a baby looks like with fetal alcohol syndrome. And this is just one particular strategy to use in terms of helping a patient stop drinking during pregnancy. I think, again, some cultures have a belief about, oh, it's the holidays, I should be able to have a glass of wine with Thanksgiving, or I want to celebrate my husband's new job with a glass of champagne. Where I used to work, we had midwives, and a lot of times the midwives kind of had that philosophy of, oh, an occasional drink is not that bad. And again, the newer evidence coming out now is like, no. So I think you're going to see varying degrees of advice from healthcare providers, but kind of the safest strategy is no alcohol whatsoever. And then for women over the age of 35, one of the things to think about is that's often a delayed pregnancy, so it may be somebody who's had a very kind of established career and lifestyle. Maybe it's a very wanted pregnancy, they've been trying to have a baby for a really long time. Women over the age of 35, we tend to see more diabetes and hypertension, just as we would in the general population. We see more of that in pregnancy. So there could be more complications in the pregnancy. It may be a high-risk pregnancy. The other big thing that we see in older women having children are multiples, so multiple gestation, twins, triplets, and then genetic disorders. So Down syndrome, trisomies, things of that nature, congenital heart defects. Some of that may be due to some of the health conditions that the patient has, and that's contributing to, again, errors in chromosomes, replication, and cellular replication in the first trimester, especially if the patient's on medication for the chronic disease. So we'll talk about different types of genetic testing, and again, this age number may change, so I wouldn't get too hung up on 35, all of a sudden you gotta have all these screening tests done. But we talked about the quad screen. The quad screen is an optional test that's done right around 16 to 20 weeks, 18 to 20 weeks. And so it would not, so it's very common, I would say, for someone who's over the age of 35 to have a positive or an abnormal quad screen when in fact the baby's fine. Okay? Because remember, it's just a screening test. We need other testing to be definitive or diagnostic. So on to nutrition.